Thank you so much, sir. And good evening, everyone. And thank you, Diabetes India, for giving me an opportunity to be here today. So, two things would be very important in my talk. One is the dual action therapies. What is the action and what is the duality of it? And how we are targeting diabetes and CKD together, and what are the recent advances in that. So, just a statement that there is a rising prevalence 3,351 patients per 100,000. There is a 26.2% rise. This is the GBD study. There is a high ESCKD incidence around 150 to 100 per million of population, and diabetes is accounting for 25 to 31% of CKD in India. And severely increased albuminuria is majority of patients is not present in our population, and risk of hospitalization is increasing day by day with the EGFR decline. The problem is that we are not paying much attention to CKD, primarily because the patient of CKD dies uh, from cardiovascular diseases before they succumb to the end stage kidney disease. There is a sixfold more likelihood for these patients to die from CV causes, and a 13-fold from any other cause than they progress to ESRD or kidney failure. Now, one important aspect here is Dr. Arvind also pointed out how to screen. Now, screening is very important because that is how you sensitize yourself. Two important points here: spot urine ACR, which was being discussed here. One important thing that you need to understand is that urine PCR is not a surrogate for urine ACR. You don't start with urine PCR. Many times the labs will give you urine PCR and you would believe that it is giving you a report for urine ACR. Well, 80% in PCR is Tom Horsfall protein. So every time you begin the treatment, you should have a report from a standardized laboratory that is giving you urine ACR, not PCR. You can follow up with PCR if you want to, but then again, at least one report from the lab to establish the diagnosis, to establish the screening record, it should be a urine ACR. The second thing is, don't use serum creatinine as a surrogate for EGFR. Use the Crockford Gault formula. There are several EGFR calculators which are present on the mobile. Just don't go and be lazy about labeling serum creatinine, because serum creatinine of a wrestler and Mother Teresa are not going to be the same. We always say that serum creatinine of 1.1 in Khali and serum creatinine of 1.1 in Mother Teresa are way apart, because Mother Teresa doesn't have a muscle mass. There is no muscle breakdown. She's a lady. There is gender bias down there. So you have to understand that EGFR gender bias should be taken into account. EGFR muscularity has to be taken into account. So a patient who's having a serum creatinine should be taken into that perspective, and don't use serum creatinine as a surrogate. Now, when we talk about dual action, there are certain things that we need to consider, and we need to understand that we are not tipping out the balance out here. We have to look at the several aspects. And what have been the considerations till date? We have talked about saving the kidneys by glucose control, by blood pressure control, by lipid control, and also in our country, especially, which Americans won't talk about, is infection control, especially UTI in specific circumstances of kidney health, because our patients, they have possibilities of having recurrent episodes of UTI, and that also affects the kidney health. But primarily, you would know that every talk has actually embodied the concept that if you are having a good glucose control, the kidneys would be saved. And that is the primarily just till date. The Now there has been a paradigm shift. Now they say that you can have glycemic management, you can have blood pressure management, you can have lipid management, but also think about agents with cardiovascular and kidney benefit. That is the new recent advance that has come, and we are heading more and more into that approach, that we have to talk about agents with cardiovascular and kidney benefit. And that is the most recent advance that has come up, that out of these three pillars, it is very important for us now to start medicines for the patients which are going to actually benefit their renal profile. And in spite of the fact, now what is evolution? Evolution is not something that is always happening in the nature. Evolution is also happening in science. Just to put it in perspective, we started with the Edison's bulb, which is a light bulb, no, common light bulb that we used to use. Then we started to use the tube lights, which were CFLs. But now nobody is using light bulbs, nobody is using CFLs, everybody is using an LED bulb. And that is what evolution is all about. Same kind of evolutionary pillar of therapy has happened. This is a very interesting article coming from Beckeris. The evolution of pillars of therapy to reduce heart failure risk and slow diabetic disease progression. We need to understand that diabetic disease is a slow, very slow, indolent, and a very progressive kind of a disease, which is not going to do anything dramatically. If ma'am also pointed out that if there is going to be a sudden change in, creatinine from, 1.5 to suddenly 5, you need to look to other causes. You're not looking that diabetic kidney disease has caused the havoc in the body. There has to be some other disease that is complicating the picture. The indolent change that is happening in this slow dramatic process is there. It is slow and it is seedlessly, just progressing. So these are the pillars of therapy that you should be focusing on. These are the recent advances. You have to look at the RAS blockers, you have to look at the SGLT2 inhibitors, and you have to look at non-steroidal, mineralocorticoid receptor analogs. These are the pillars that they maximally slow the kidney disease progression, and they reduce heart failure risk as well. Nonetheless, notwithstanding, irrespective, where is the duality of action? I talk about SGLT2 inhibitors, I talk about GLP-1 receptor analogs, and they are excellent drugs that cause control of blood sugar as well. Now the question is that you would ask that why cannot we attribute this entire phenomenon to a good control of blood sugar? You would ask that question that, okay, these are excellent agents which are controlling the sugar values also. Then why are you saying that the kidney protection is happening through these agents? And probably to answer this question, several recent studies, they started to explore the different interventions across a range of patients of CKD, whether they were diabetic or they were not diabetic. That was not the case. So they needed to establish in the non-diabetic population also that these medicines are working as kidney protective agents. And if you can establish them as a kidney protective agent in non-diabetic patients, then you are having a dual action, because they are having a kidney protective action which is established already in the non-diabetic patients, and in the diabetic patients, because they are also controlling the blood glucose, they are also having the other action. And that is why there was a, foray in the market, there was foray in the pharma space, there was also foray in the medical space to do trials on non-diabetic patients as well. Credence, Fidelio DKD, DAPA CKD, Figario DKD, EMPA kidney, Flow, all of these trials, they are also, enhancing our knowledge, because they are taking into account the patients who are non-diabetic as well. So let's talk about one trial, about EMPA kidney trial. Uh, in the interest of the time, I'll go very fast on this. EMPA kidney trial was, of course, a large inclusive CKD patient population, 6,609 patients enrolled. 54% of the patients were without type 2 diabetes. 35% patients had EGFR less than 30, 48% had EGFR, USCR less than 300, 73% patients had no prior history of cardiovascular disease, and 28% patients reported kidney biopsy. And more importantly, only 31% patients had diabetic kidney disease. 25% patients had glomerular disease, which excluded patients with diabetic kidney disease. 1445, that is 22% of the patients had only hypertensive renovascular disease. 12% had CKD of other known causes, and 10% patient had CKD of unknown causes. And what do we find? Look at the confidence interval. It is, favoring empagliflozin all the way. It's just establishing the fact that empagliflozin is having a role not just in diabetic kidney disease, but also in non-diabetic, into kidney disease with no diabetes as well. And the results are absolutely gratifying. The empagliflozin also constantly reduced the kidney disease progression or the CV death across the spectrum. Look at the hazard ratio of 0.72, not even crossing the line of unity, confidence interval being 0.64 to 0.82. And this is about overall CKD patients. And this is the slide that actually puts the gist of it, that now KIDGO establishes the 2024 guidelines recommending SGLT2 inhibitors for use in people across the spectrum of cardiometabolic spectrum. So on the left side, you find that it is an established medication for CKD and type 2 diabetes, for CKD and heart failure. And on the right hand side, you find that it is an established treatment for CKD as well, alone. So this is where these new age molecules are changing us as we talk. And this is where the evolution is actually happening. Thank you so much.